next speaker is Dr. Katie Plax. She's an associate professor in the Department of Pediatrics at Washington University School of Medicine. It's really an honor and a pleasure for me to introduce her. She's an esteemed colleague, and I'm really proud to call her my good friend as well. Katie earned her MD at Rochester University in New York. She completed her first year of pediatric training at Boston Children's Hospital, and then we were lucky enough that she decided to return to her home in St. Louis and complete the rest of her training at St. Louis Children's Hospital. She is somebody who truly has devoted probably most of her life, but definitely her career, to changing the health of people who are members of disadvantaged populations. She's done this through direct patient care, teaching, advocacy, as well as research. Our committee, our lab team, as well as members of the sickle cell team from WashU, made a very short list of people that we wanted for speakers. Dr. Howard was our first choice for the keynote speaker. Dr. Plax was our first choice to help with the adolescent population. And Peter, who's going to speak next, was our top choice for the more governmental policy piece. So we were really happy that everybody gave up their time to travel here and help educate us all. One of the reasons we chose Dr. Plax is because you really can't think about advocacy within this area without thinking of Katie. She has helped to advocate and change care at a local level. Right out of residency, she could have had a job with any academic center or any private practice in town, including her family's, and she declined those things and chose to work at a local FQHC. Even in that short year that she worked there, when I worked down the street at Christian in pediatrics, I could see the difference in the care that she provided to that population at that FQHC, and she also devoted her off hours to writing for grants for things like a refrigerator freezer so that that FQHC could receive more of the immunizations that they couldn't actually store. At a regional level within Missouri, she for years was the legislative chair of the Missouri American Academy of Pediatrics Committee. And then at a national level, she's also been recognized. In one way, she was recognized by being awarded a really prestigious fellowship from the Soros Foundation. During that fellowship, she actually organized a campaign to provide 90,000 children who were uninsured but income eligible through the Medicaid and CHIP program. She's been recognized by being asked to speak before the Congressional Black Caucus, and she's actually given up her morning to share some of her work with adolescents here. One of her major accomplishments locally was developing the SPOT, which all of our local team members are very familiar with, but for those of you who are not, she'll speak more about this today. But the SPOT stands for Supporting Positive Opportunities for Teens, and probably anyone between the ages of 13 and 25 near the medical center has spent some amount of time there, and we're very grateful for that. So Katie, please come up and share with us our next talk.
That was a really nice introduction. That's what happens when a friend introduces you. You know, they like to give a few highlights. I too, I think like Dr. Howard, really enjoyed kind of some preparation and learning that I did around the medical home. And it's really a pleasure to get to share that with all of you today. I always like to start with objectives, but we don't have to be so formal here. But this is my plan of what I'm really hoping that we can get through today. So as you can tell, I think I might take this out actually, walk around a little bit, less formal. As you heard from Allison, I am very passionate about advocating for children and children's health and family well-being. And I always like to look at our pediatric history for role models of people whose lives I would like to emulate. And when you look at the history of the medical home, you come across actually another example of a professional advocate, pediatrician, who really kind of transformed care for children with chronic illness. And the other thing I'll say is that this is yet another person who transformed the country, who happens to be from Hawaii. So this is Dr. Carl Sia, and he actually was born in China, and when war came to China, his family fled to the US when he was just starting his adolescence. His grandmother was an OBGYN, and in Hawaii took care of folks by doing a lot of home visitation. And Carl would accompany her, Dr. Sia would accompany her in those visits. After he returned from his own stint in the war, he actually, in the Army, he actually attended college and medical school. And then in 1958, he became a practitioner of pediatrics. And he specialized actually in caring for children with special health care needs and medically complex children. And he focused I think actually very similar to Dr. Howard's story. You know, he was doing this, it didn't really have a name, he thought it made sense, and then decided actually to formalize it and take it actually well beyond Hawaii. He worked really hard to really establish a comprehensive medical home where there was continuous care and coordinated care for all the children that he served. So he decided this was such a good model in his own practice that he wanted to take it statewide, which he was able to accomplish. And from there, he actually in the late 80s and 90s was able to take it to the Maternal Child Health Bureau, who supported a national training initiative. And get this, everybody part of the National Training Initiative got to go to Hawaii for the training. Yeah, it was a tough sell. So that was kind of an added bonus for those early trainees. And then in 1992, it was adopted in a formal policy by the American Academy of Pediatrics, which is really a national body that provides advocacy for children and supports pediatricians in their work. And so this is really where we are today. So as you can see, the Maternal and Child Health Bureau still supports the Medical Home Initiative, and so does HRSA, and so does the American Academy of Pediatrics. So the lessons I think we learned from Dr. Sia are that a passionate concern for patient interest matters. It matters in taking care of all kids, and it especially matters in taking care of kids with special health care needs. He maintained and demanded a high level of technical competence. We heard from Dr. Howard the importance of tracking this and keeping tabs on is what you're doing making a difference, and Dr. Sia was really a model for that. He was also a model for any of us who are interested in being advocates. So he recognized that we had a public role to play and that our civic engagement really mattered if we wanted to change the lives of children and families. And he was especially focused on children and families that had special health care needs. So I hope from that history that as we go forward, we think about ways for all of us to be advocates in the work that we do, and that we give homage actually to his amazing life story and trajectory. So I thought I would actually do a little bit of actually describing what we mean is the medical home. And this actually comes from that AAP policy statement and has been revised and reapproved with some more nuances. But these are really the core elements, and we're going to walk our way through these. So accessible. So I think actually Dr. Howard gave us a great example of that, of being accessible in your own community by that urban-rural partnership. That all insurance, including Medicaid, is accepted, and if you work with teens and young adults, it also means you're going to be seeing uninsured folks, and that the practice, and this is especially important in urban areas, is accessible to public transit, or if you're serving youth populations, you'll hear later, we really have to be close to public transportation. ADA accessible, that's part of access, and that families or youth can speak directly to their practitioners when needed. Continuous, this is really about continuity, consistency, that it's developmentally appropriate, and that we also communicate across facilities, which, between hospitals, community agencies, community health centers, that's really what we mean by continuous. Comprehensive, so that we're really trying to facilitate all aspects of care, and that preventive care is included in that. I think especially for children and adolescents with chronic disease, often the general preventative wellness work gets missed and doesn't necessarily meet actually the young person's needs. And then we can't forget about education and people's lives and the complexity of people's lives when we're providing comprehensive services, and that frankly kids with special health care needs need more time. And I've already talked to you about physicians need to be advocates. And then family-centered. So this has been a big kind of plug at St. Louis Children's Hospital, and it's something that all of us in the medical profession need to work harder on. We need to make sure that families really have access to it, that we share decision-making, that we make it actually work in a family's complicated life, and that we recognize that families are really a strength and something that we want to support for our children in their medical home. And then coordinated, I think this was reinforced probably better than I can in this definition with Dr. Howard's examples. But really that it's very important that all of the different care providers are working together, understand the plan, and are supporting children, youth, and families in carrying that plan out. And we can't forget, we can talk about coordinated, we can talk about quality, we can talk about family-centered, but we also have to have empathy. And we have to really demonstrate our caring for the people that we serve. And then culturally effective. So I think if you're involved with sickle cell disease, you understand the importance of culturally effective and competent care, and that we really need to value our patients' customs and beliefs in our care planning and coordination. That includes language and translation if needed, which is also protected under the Civil Rights Act and is really important if our patients don't speak the same language. Okay, so lovely definition. Oh, the words sound so nice. We're all singing Kumbaya. Of course we believe in that, right? So, but the point is, here is, does it work? It sounds great. I love all those words, but does it work? And so I'm going to show you a couple different studies here that just demonstrate that, yes, in fact, this is a model that works. So this was a very large study looking at a national survey that's done on children's health. It's a random telephone survey talking to parents with kids, 80,000 across the country. And what they found was, and this was all comers, so it did not select out children with special health care needs, which is what children with sickle cell disease would fall into. But anyway, about half the kids had a medical home. And that the medical home actually meant that they had lower unmet medical needs. They were more likely to have had a preventive visit in the last year, and they also had lower unmet dental needs. And we know dental is like a big service that a lot of our children and youth need. I see a lot of mouths with a lot of cavities, and that is probably the most common chronic illness. But the other thing that this study showed is that we had large disparities based on race and poverty, and that frankly those in poorer health were less likely to have a medical home. And so we clearly have some work to do to bring the model to a more widespread and really a more needy population. So this was another large study that was done that was specifically looking at kids without any kind of chronic illness or special health care need. Again, from a large national survey. And again, you see that increased preventative care visits were associated with kids who had a medical home, decreased ER sick visits, that parents actually felt better about their children's health, and other things in the home were actually good too. So there was more reading. There was actually more kids wearing bike helmets. And there was actually decreased screen time. So there was something about this medical home that was good for kids in general, not just good for their health. And then this study actually looked at kids with special health care needs, so really where our population of kids with sickle cell disease falls in. And again, the medical home model is really supported in a review of the articles that were published in the medical literature, which was really better health status, improved timeliness of care. The families really felt like they were more included in the care and the planning. And by the way, that family functioning thing again that we're talking about was better for kids with special health care needs who were in a medical home. And then again, this study published on children with special health care needs, again looked at quality indicators in general, but also one of those quality indicators was a medical home. But what I thought was interesting is they kind of broke down the components of the medical home in this study. So you can see a lot of these kids had a usual source of care. So they had a primary care doctor and a regular doctor. And they didn't really, a lot of them, almost 80%, had no difficulties with referrals. But the care coordination piece was much lower. And also having all 5 of the components of a medical home that these folks looked at was much lower. And so we clearly have some work to do around that, and I'll show you a study specifically on kids with sickle cell disease where that care coordination piece is clearly something that we need to work on nationally. Again, in this study, disparities still existed that reconfirmed that previous study on race, poverty, and language. So we clearly have race disparities, and we clearly have income disparities, and we clearly have issues with getting people whose English is not their primary language access to our care and service. So what about for patients with sickle cell disease? So I have to say, I was completely shocked by the lack of data for patients with sickle cell disease in a medical home. So I did a search by medical home, I did a search by sickle cell disease, I merged them, and I only had 8 hits of things that included both of those words in the articles. So maybe we're calling it something different. So maybe I don't have the right language, maybe we have a different word for it, or maybe we're not doing it and we really need to light the fire under us because we know it actually helps kids and families do better. So this was actually a large study just published that was done at Baylor. So that's the large children's hospital. And they looked at their population of children with sickle cell disease, and only 11% had a medical home. Now, as you can see again, a lot had a doctor, so 90% had a doctor that they called their primary care provider. But when you get down to care coordination and family-centered care and comprehensive care, we're not doing as well. And this is a very large children's hospital. So, this is the only thing I could really find published specifically about children with sickle cell disease in the medical home. So we've got some work to do. So I think it just makes this conference very timely for us all in thinking about what we want for children and families with sickle cell disease, but also what we want for other kids with chronic illness. Because as Allison said, this is probably just a reflection on the issues that we really need to help address for children and youth with any chronic illness. So, and I think the reason the care coordination piece is so important is that in other studies of children with chronic illness, care coordination has been associated with shorter hospital stays, as Dr. Howard mentioned, lower costs, and that parents are happier with the care that they're getting, and that we're really fostering strong relationships with a patient's primary care doctor. Okay, so then I thought, well, like if, the group of kids that we really want to address isn't getting the medical home, what are some steps that we can do to try and build that for children and families in our community? And I came across a large body of work that was done by this Safety Net Medical Home Initiative. And they really put together 65 practices across the country with the goal of setting up and establishing medical homes. And it was published this year in a Commonwealth Fund report, and that's the name of the report. It's easily accessible online, and it's actually easy reading. So there's some nice case demonstrations that I think really bring home why a medical home is so important, and so I would definitely recommend checking it out. The other thing that I really liked about this was they actually demonstrated through their work some key guiding transformational issues that if you want to build a medical home, you should really invest in and think about. And one, and I think we actually saw the beautiful demonstration of that in Dr. Howard's talk about engaged leadership. So really you had the community-based organization driving this, you had a hematologist driving this, you had leadership at a federally qualified health center, but engaged leadership to actually keep reinforcing the importance of developing the medical home in the practice. And this includes actually time and training. So this isn't something that's just about being a cheerleader, it's actually something that you invest in and train your whole team in. The other things that they mentioned were quality improvement, so that we actually look at data and that we actually receive data from patients and their families about what the experience is like for them, and that we act on that data and that it informs change in our practice. Empanelment really means that you know who your doctor or practitioner is, and that that's the person that you establish that primary relationship with. Continuous and team-based relationships. I think we also saw good examples of how important a team is in Dr. Howard's work. So when the transcranial Doppler person left, we saw a change, and the same thing happens in teams. If care coordinators leave, if the social worker leaves the team, these are really important and critical roles that help patients and families get their needs met. And so having people understand the critical nature of their role and how we're all going to interact and work together as a team really matters. So we have to be organized, and we want to make sure that our decisions are based on the best evidence we have out there. But there's no question about it that it takes resources, and I think that to implement a medical home takes a lot of people, but it also takes training, and it also takes teamwork and time, and that means money. So patient-centered, I think we in pediatrics probably are not as well trained as our adult colleagues are on helping people with their own self-management. I always say, like, some of the things I really needed to know in what I do now with teens and young adults, I always wish I had more training on coaching people about their own self-management and their and coaching people about coordinating, making their care real for them in their real lives. And then I think enhanced access. We heard about the importance both for primary care doctors speaking with specialists in the early example, but it's also really important that patients and families have access to us and the information that they need. And then I gave you a good spiel about care coordination. But we have community service agencies here, and they play a really critical role in helping children and families get their needs met. There's also important behavioral health strategies, and then schools play a really important role in helping our young people succeed and reach up to their full potential. So those are really the 8 key guiding transformations. And At this point, I'm going to switch gears a little bit and talk about how we use some of this at the SPOT. And the SPOT stands, as Allison said, supporting positive opportunities with teens. And I'm going to tell you a little bit about how and why we developed the SPOT, and then how we've tried to incorporate some of the elements that we just went through of the medical home. We're not there yet. We're a work in progress. We're about 4 years in. I was actually very encouraged to hear about the 24-year trajectory. So that actually makes me, I was like, oh, okay, so I'm about right. So at about 4 years in. And I think the other thing that really points to, and that Dr. Howard gave a great example of, is really this notion that's being talked about in education, but also in youth care and services, is this notion of grit. So the ability to stick with a problem in the face of great frustration or great challenge, and the importance of sticking with it. So I think that was a great example, and actually really heartened me about kind of the trajectory I'm on. So when we were thinking about creating a youth center here in St. Louis, and any of you from St. Louis, you often see that lovely headline in the St. Louis Post-Dispatch, yep, we're in the top 5 again for STDs. And I was seeing this in my office, and frankly, it was driving me nuts. You know, like, how much chlamydia can I treat, and how much can keep coming in my door? And while I'm very good at treating chlamydia, I really thought that's not what this is about, right? There's so much beyond the 4 walls that we really have to address if we want our young people to succeed. And you can see that youth are where those cases of STDs are, right? And unfortunately now, we also have diseases that we can manage, but we can't cure, like HIV. And HIV is disproportionately impacting young African-American youth in our community, in particular young men. And the other thing I looked at was mental health disorders. So, and that our young people are coming to our emergency rooms with mental health disorders that are treatable, and they're ending up in our ERs because we're not meeting their needs. So what gets in the way for young people? So, and here I'm really talking about adolescents, young adults, the 13 to 24-year-old age range. And so I don't think any of these to anybody in this room would come as a surprise, right? So cost, how am I going to get there? Are people going to keep my private stuff private? Because really privacy is very important to young people. Insurance, so in this, you know, hopefully we're going to get over this healthcare reform hump, and hopefully Missouri will actually participate in healthcare reform. But there is no question about it that when our folks turn 19, a lot of them lose their access to health insurance. And then fragmented services, so I gotta go here for my doctor, I gotta go over there for my lab, and I gotta go over there to pick up my prescription, and my bus transfer only lasts 2 hours, right? That's like a real barrier to care. So, and I say actually disenchantment with adults is actually a reasonable disenchantment with adults, because frankly, for a lot of the young people I see, adults have not been supporting them. So, in fact, you know, they may actually really be thinking that their peers are more supportive than their adults in their lives. And so we actually have to overcome that as trustworthy adults. And then just all the documentation and verification. You know, it's like you gotta have your driver's license, or you gotta have a photo ID. It's not just for voting, it's also for healthcare. We really ask a lot of documentation from people, and really it gets in our way. And then how do I navigate this system anyway? And frankly, as a professional that works in the system, I find it difficult to navigate. So how is a 14-year-old who really may not have a trustworthy adult in their lives supposed to navigate this beast, right? So frankly, those are really reasonable things. And then you can see that on the flip side of it is to serve young people well, right? Like, no surprise, they kind of mirror each other, right? So you gotta have everything under one roof that you can. You gotta have it near public transit. You gotta have a team that knows their roles and can coordinate really well together. The environment's gotta be welcoming. And the adults in the space have to really reinforce the positive things that young people do and the staff have to be passionate about working with young people. So this is what one definition is of positive youth development, but it's really about young people developing to their full potential. And that during their adolescence and youth that we're helping with them develop the building blocks for their future success. This is a model of positive youth development, and if anybody wants to pick one book that's really readable that I think really captures the essence of how we should be working with youth, it would be this book, Reclaiming Youth at Risk. And these folks actually run trainings, and I just really love their work and all the efforts that they've put in. And they describe these 4 characteristics that we as adults should really be reinforcing with young people. So belonging is really about unconditional love, right? That someone loves you and supports you no matter all the mess ups you do, right? And we all have made mess ups. So mastery is that you're good at something and you're recognized in your community for that good something that you do. So it may be, it can be that you're, the star football player, but it can also be that when a kid gets hurt on the playground, you as the 4th grader are known to be that one who's going to be first there. That's mastery. So, and that's good. Independence, that you're able to be responsible for yourself. And then generosity, that you're able to give back to your community. These 4 elements are what that circle of courage really reflects. And that circle actually comes from the Lakota tradition, which is a Native American tradition that really reinforces that you need all 4 elements for that circle to be whole, for the person to be whole, and otherwise, if the circle is broken, the person's broken, and we've got to work to make the circle whole again. This just makes sense to me. And it's 4 things, and I can keep 4 things in my head that I can work on with young people. And you can you could call it the big M. I also call it GIMBY, so I remember all 4 things, which sounds like Gumby, which makes me think about Saturday Night Live, which makes me laugh. So keeps it in my head. So anyway, so I just pass along this to you because this has really been the framework we've used at our youth center to really work with young people and reinforce the positive qualities that they bring to us. So really, it's about highlighting positive. It includes a youth voice. We have a youth advocacy committee. They meet monthly. There's about 20 youth who participate. They have done everything from tell us what colors should be at the spot to interviewing staff that we hire. They really to telling us what the next programming should be, to looking at our programming and telling us, I think you need to tweak it a bit. All of those things are really experiences that the Youth Advocacy Committee has given to the program. It involves long-term involvement. There's got to be that community and youth center partnership and this strong focus on collaboration. So I just kind of put these side by sides because I think it helps people to see the difference in the positive youth development model versus kind of traditional youth services. So, and then I always put up this because it is very difficult for people to develop generosity if their safety and basic needs are not being met, right? So if you're hungry, if you're worried about whether you're going to have a roof over your head, it's really hard to develop generosity. So we can't forget that people's safety and basic needs have to be attended to in order to develop their circle. And I would say some of you may be trained as social workers, and I think social work was actually well ahead of medicine in looking at a strength-based approach. And so this is really, one author's view of what a strength-based approach is. But this is really what we're trying to foster and nurture in our center and in our interactions with young people. Which is that basically people are active in their own helping, and that strengths are really the motivator for change. And that these strengths actually can be within the person, but they can also be within their environment. So both are good. And if you have one without the other, that's okay. It's good too to start with some strengths that are available to you to access to make change. So I think this is just, if you're working a lot with young people, these are some of the things that I have found to be very helpful, and probably like Dr. Howard at the end, I'm going to tell you kind of a few things that I've learned, and it's generally learned by messing up. So one is that we really need to try and listen for the strengths that we hear in young people. So I say identify is probably the better word than asking, because a lot of times if you ask young people, like, what's your strength, they kind of look at you like, well, you know, I work out every day and my biceps are getting bigger, you know, because they're really like concrete, right? That's where their brain is, right? It's concrete, like strength, okay, yeah, I could lift 100, okay. But if you are listening to kind of the stories, then sometimes you can hear where they've been generous to another person, and you can really, you know, comment on that. Or sometimes you can hear, you know, where they're really talking about the connection they have with a family member, and you can talk about, wow, it's really great that you have that unconditional support from your family. And so we can highlight those back to young people, and it's always fun to do because generally they're like, wow, you know, for one, you listened, which always is nice for people, for anybody. And two, like you heard something good about them, and who doesn't like some positive feedback about yourself? So it's a great way to build a bond, and I think it really encourages young people to keep doing those good things. The other thing is about if we really want something to change, if we're not liking some of the behaviors we're hearing, it's very helpful to use shared decision making. And so often, you know, people will say, I mean, I think most young people actually recognize some of the stuff they're doing that's not so good for their health or well-being. And they'll recognize that, but then they're not sure what to do about that. And so sometimes I'll just say like, oh, you know, I heard you say that, have you thought about what you would like to try? And then I try to get really kind of, because most youth are more concrete thinkers than most adults, is to think about, well, you know, what would it look like if you tried that? You know, or what do you think you would like to try? And what does that really look like? And could we practice that? Could we try it out here? What would that conversation look like that you said you wanted to have? And so we've got a lot of work to do on shared decision making and incorporating that strategy into our effort. And then it's really important that we get continuous feedback from young people that our places are comfortable for them. And this study just kind of reinforced that, you know, paying attention to privacy, having youth-friendly stuff around, discussing strengths, posting volunteer opportunities that young people can participate in, so kind of really reinforcing that circle in practice. Actually, in this study, not only did young people like it better, but so did the people that were actually practicing medicine there. So it actually made their interactions with adolescents more enjoyable, and they felt like they were making more of a difference. So we kind of took all that stuff, so we recognized the need in our community. We really fell in love with this positive youth development model, and we used that to develop our youth center, The Spot. And this is what we do. So our services are free. We have health and social services together under one roof for 13 to 24-year-olds. We've got two programs where we're really being the medical home. One is for youth in foster care, and another is for youth who are infected with HIV. For the other youth who come use the Spot services, we're more a drop-in, walk-in, and we haven't quite reached our eventual goal of being the medical home. Our services are drop-in and walk-in, partly because we want young people to feel like they can just come by and that they're welcome to a safe place that they can hang out in. We do a lot of, I talked to you about the Youth Advocacy Committee. That really is so key to our care and services, and I'm very grateful for the young people's gift of time. Making a commitment once a month for a year is a significant commitment. We do a lot of STD and HIV testing and treatment and contraception and pregnancy tests. We have a mental health counselor, we have a psychiatrist and a psychiatric nurse practitioner who are there 1 day a week. We have our substance abuse counselor who's there every day, case management services, and we have a job training coach and career development person that we actually share with SLATE, which for you St. Louis folks, that's our St. Louis Area Training and Education Agency. Here's our crew in the spot. So, yay. Cranes made by youth. You just can't sing enough the praises of a team. Like, it really takes a team to do this work well. And like every day, I just thank the people I work with and am very grateful. Can't do it without money either. And if you're providing free service, it takes money for every single thing you do. So these are all the folks who have helped us along the way, and we're very grateful for that. And then this is what these are our 4-year numbers. So we've seen now over 6,600 youth. You can see about 60% female, 40% male, and we also do serve a transgender population. There's our race breakdown and our age, and typically there are about 25 to 35 youth in this space every day. And we've provided, you can see the services we picked were clearly endorsed by youth, and they've used them. And so I think actually going in, we did a bunch of surveys with youth. We went to a lot of youth community events, and we asked, what should we have in our center? And youth basically told us they wanted STD and HIV testing, they wanted actually mental health services, and they wanted job services. And so this is our Dave Letterman top 10 list for the spot. But this is actually, I mean, what I think is so interesting is that actually what you said they want, they're using, which is great. And the other thing that I would say is the top 3 are really important. So one room that we have is a drop-in space, and I feel like that drop-in space really lets young people kind of check us out and make sure that we're trustworthy. So for a lot of youth that we see who are homeless or runaway or have been involved in the child welfare system, they really need that space to check us out. And so I'm glad that we have the drop-in space, because I think it really enhances the access to all the other services that young people need. And so I told you I'm like a stickler about, so one of my goals was that St. Louis not be, leading the way of the country for STDs in a metropolitan area. I'm not sure actually where we are this year, but I do know where the spot is. And like my folks all laugh at me because like every month I'm like, okay, what's the percentage this month? How many kids do we treat? This is like my quality thing for me. This is my, and I feel really good that despite our very high prevalence numbers, these are very high percentages, that 95% of the young people are being treated within 4.5 days. I'm also really, while I would like that number to be higher than 80% for those linked into care and services, some of the young people that we see that have tested positive for HIV really have had some pretty horrific life experiences that I wish were different. And I hope that over time that 80% will be higher, because clearly they need access to medical care and services. And then that last bullet is really, Ryan White is the funding for folks infected with HIV. Part C and D youth actually fit into both the adult and the kid programs, and that's just what that reflects. And the good thing is that 30% of the youth, of folks in those services are actually coming to the spot. So that's great. So, and then this is one of our, we're now just starting year 3 of a grant that we received from the Office of Adolescent Health, where we're really trying to improve the care and services for youth in foster care. And again, this is really the medical home model, and we're really trying to provide comprehensive care, including mental health and dental health services. And this is what I've learned. There's no staple, easy buttons for kids who have been in and around the foster care system. This is actually a foster youth alumni made this. There's a great foster youth alumni site, and some of the foster youth alumni created postcards so that people could understand their life experience. And I thought, wow, how great, you know, like, yeah, that shows it like in a nutshell in one postcard. Pretty incredible power of young people. So I wanted to kind of reflect back on where we are in our own organization, in our transformation, and in those 8 kind of qualities and indicators that help you become a medical-centered home. So I think we really do have engaged leadership. We meet monthly, our staff meets monthly, and we also have huddles of our care team, which is really like right before our clinics. We kind of meet for a few minutes and know what it is we're going to try to accomplish for the young people who are on our schedule for that day. And we also huddle at the end of our clinic for about 10 minutes, just to kind of say, okay, what's next? What are we going to do? And in very short order and in really without a lot of time, we can actually do a lot. So I'm a big fan of the huddle. Yeah, football had it first. Okay. So any of you who play football probably are like, yeah, the huddle works. Hello. Like, we do it in seconds and we're out there again and we have a plan. So yeah, medicine was a little slow on the uptake. So quality improvement. So this, I think, from Dr. Howard's talk, you understand how important quality is and that we can measure it and that we can know what we're doing is making a difference. We hired a data management person, and we really track some specific indicators about what we're doing. We're always interested in adding more. We actually have our electronic health record system is different than anything at any of the hospitals. You gotta love that, but anyway, what's nice about our system is that we can see kind of all the different roles that have engaged with a young person. So we can actually see that they've met with the substance abuse counselor and the case manager, and we can actually see that in real time and know kind of all the different people involved in the young person's care, even if it didn't, you know, and so that's really helpful to team building. Empanelment, so we do have primary care folks for our HIV, for our youth infected with HIV, and our youth in foster care. For our other youth, we're not there yet. Something for us to work on. And then this whole kind of building of team, I think we really do understand our roles, and all day long we have regular handoffs between each other and the different services. I think it's great to have all those people under one roof. You know, and that's been, I think, a huge success for our program. Our care is evidence-based, but we don't have like a computer program or electronic means of informing our decision support, and that is something I'd eventually like to have. So I'll always talk about how we need more self-management coaching. You know, I think this is a really important part of helping people care for themselves when they have a chronic illness. And we do have nurses on call and case manager, and they always can get to the physician on call, and so that has been very helpful. And then lastly, the care coordination. We do provide care coordination, and the physicians, social workers, and mental health folks work closely together. And sometimes we can't accomplish the things we want to do, and sometimes the young people aren't ready to engage. And so kind of the effort of patience and grit and persistence really come into play when you're talking about care coordination. So, okay, so I'm always about wanting to expand services. I'm always trying to keep what I have. The sustainability thing for us is always a challenge. And then the advocacy piece, as Dr. Howard mentioned, there is a lot for us to do to make this country and our community better for young people. So I want to take 1 minute to just talk about the stuff that gets in our way, and then I promise I'll stop. So this is what I found has gotten in the way, and adultism is the kind of stuff we do to young people, you know, when we put them down. So, you know, you're too young to understand, and, you know, you'll do it or else, or I'm not going to listen to that. And it's really when we're being disrespectful to another person's point of view. And, you know, some of my colleagues were funny and reviewing these slides with, you know, because I always like to get my friends' feedback, and they were like, I don't think this is just an adultism thing. I think people say this to other people in general. So I think it's probably some of both. So I think what helps us be better adults in interacting with young people, and especially young people with chronic illness. So I think we need to reflect on ourselves, and we need to work on our listening. We need to have kind body language. So one thing about teenagers, they are really good about picking up judgment. And in fact, when we look at brain studies, there are areas of the brain, the amygdala, that are most sensitive to judgment actually are much more sensitive in adolescents' brains. So even more important that we have kind body language when we're working with young people. We got to build teams. We have to manage our own stress, and we have to nurture our appreciation of diversity. So a couple of the things that I've learned is one is from a patient who is in foster care. And this young woman I have known for now probably at least over 5 years. And she's been in and around foster care. She's really endured a lot in her life. And the thing about her is, I will, you know, ask her, like, what does she want to work on today? And she'll tell me something, and maybe it's contraception. This was one example. And she'll never, ever take my advice that day, ever. Like, it just will not happen. So, but always, like, in the next visit or the next visit, she'll bring it up again. And she'll be like, you know, you told me about that, and I've been thinking about it. And I think I'm going to do that today. So it's a really important lesson for me in that to remember that even if somebody didn't take, you know, any of our advice that day, it doesn't mean down the road they're not going to have heard it, and that they're not going to do it in their own time when they're ready, when it works in their life. And so I really try to remember that because frankly it helps me be less discouraged some days, you know, because there's going to be some hard days in this work. The other thing that I've paid a lot of attention to is managing myself and thinking about my own stress. And this is where, like, mindfulness and the whole notion of persistence really come into play. So, you know, trying to be present, I use actually meditation to try and keep myself calmer when I get upset about things. Because the bottom line is that, like, this stuff should get us upset. You know, it should get us upset that people of different races don't have the same access to care. It should get us upset that, you know, with a decision in the legislature, the Medicaid program isn't what it was, and our kids don't get access to the care and services they deserve. It should get us upset. So, but I then have to do something with it, you know, and I still have to have effective interactions with the patients that I serve. So I try to keep, like, the anger in, like, the exercise realm or in the advocacy realm, and keep the mindfulness and kind of persistent calm in the patient interaction realm. But it takes a lot of practice. And then I think just if you're doing this work and at times you feel discouraged, I think it's really good to just acknowledge there's going to be good days and bad days. And that's where really a team is so helpful, because generally the team doesn't all have bad days on the same day, and that is really a gift. So, and then the last thing is, I went to this training about, like, mindfulness and managing stress, and I thought it was great and very helpful. And, like, they gave out this little card, which was this Buddhist prayer. And I mean, you can see I've, like, worn the card to shreds. But I really believe in it. So, and sometimes, like, I actually store it in my backpack I take it out, I just read it to myself, and I'm just like better again. So I'm going to read it to you here today. It's called the Loving Kindness Meditation. May we be free of suffering and the roots of suffering. May I find peace and the roots of peace. May I find wellness and the roots of wellness. May I find joy and the roots of joy. May I be free. May you be free of suffering and the roots of suffering. May we be free of suffering and the roots of suffering. And I just think that makes sense to me. And the thing I also love about this card is on the back was this 4-year-old's interpretation of the meditation where she says, "It's nice to feel the breeze when it shines." And I thought, that's it, right? We got to be reminded of the breeze when it shines. And I think that's really, what we're about in the work that we do. So I will also say that, while I'm one of the founders of this spot, I couldn't do anything I do without Kim Donica, who is a really talented and amazing social worker that I've had the good fortune to have a partnership with for the last 12 years. And that's the way to reach us, and and you'll have that on your jump drive. So if you go home and you're thinking about something, just shoot an email. And I'm also happy, I know I'm a few minutes over, to take like a question or two, because unfortunately I do have to run, but I'm with you in spirit. So, yeah.
A lot of the legislature that deals with medical homes, they for some reason decided not to call it that. So when you do your web searches for stuff, if you typed in healthcare home instead, you
Okay.
might get better luck.
Okay, I'll try that and I'll see what I get for kids with sickle cell disease. All right. We're at 4169 Laclede in the Central West End in the city of St. Louis. So we're between Boyle, if you're from here, we're between Boyle and Sarah on Laclede. We're in a it's a neighborhood.
You
Yeah.
mentioned with the spot outreach at the schools and neighborhood centers. Can you say more about what you guys have done to do that?
Yeah, so I will say most of our outreach has been through word of mouth, but we do actually, the outreach that we've done is more formal, which a lot of schools have called us to do like STD 101, HIV 101. We've also done talks with a lot of the courts and child welfare around care and compassion for lesbian, gay, bisexual, transgender youth, and just positive youth development in kind of more formal settings. But we don't have an outreach team in terms of like street outreach, which may be something that you have. So I don't know. Does that make sense?
It does. I just wanted to know.
Yeah, we are on Facebook and that kind of, the main way that young people have heard about us is frankly word of mouth and from their friends telling them to come here for X, Y, or Z, which is great. That it's been plenty. So for us to manage and care for, so that's good. We've also done a lot of work we've spoken at a lot of like primary care. So Children's Hospital has like an early bird grand rounds where primary care pediatricians come to learn more. We've spoken there. The thing I'm racing off to is actually another primary care, where I get to talk to primary care doctors in groups. And so we've also been trying to work with pediatricians in our community to help the services that they provide be more youth friendly. Because often in pediatrics we focus on little kids because we see them a lot in the first couple of years of life. And we only typically, if adolescents are well, then often it's a once a year pre-sport participation or school participation physical. Yep.
Do you do anything for youth that get pregnant? Or what
So-
services do you provide?
We do pregnancy tests and we do, but we don't have, we have an OB who works with us, but she doesn't provide OB services on site. Our case manager actually meets with them as they're figuring out what decisions they're making. We help them transition to care and services that they need in pregnancy. So there's the Teen Pregnancy Center at Barnes for those 17 and younger that provides very comprehensive care and services for young women, and it also actually includes father support groups. So it's a good program, yeah.
When you talk about mental health, since it's not that much out there for them, when the adolescents or young adults come to your facility, what do you do or how do you guide them when they're homeless to get them safe shelter or
Yeah.
to keep them on medication?
Yeah, so our case manager, her name's Rochelle Moore, and she is like pure genius. You know, the homeless problem is hard, and it's really hard for young people. There's not a lot of places that actually meet the needs of young people. And so often they're going to some of the larger shelters until they can transition into the more youth-serving programs. And then as far as like medication goes, we do a lot actually, and there's a lot of prescription programs. Sometimes the different drug companies will have, you know, different things that they support, and there's ways to look those up online. Also, certain care organizations like the Asthma and Allergy Foundation supports, you know, inhalers for those 22 and younger. So we use these different kind of piecing together of care and services to help people keep their medications that they need for ongoing chronic illness. But it's an imperfect world, you know, and there are times where we can't figure out a way that works with a young person, and we just try, you know, and do what we can do. I wish there was more.
Thank you.
All right.